quoting me as saying that the withdrawal was related to terminating Ms. Ralsted, which is not something that I said. I did not say that. It should just read withdrawal of the petition. Okay. Thank you.
So we'll strike that. Any other questions?
What's the process for that?
It just gets through.
Yeah, we'll just strike that.
And then at next month's meeting, we'll approve them?
No, it's approved as amended.
No,
Oh, I'm sorry.
No, we approved it. Yes, so we're striking that proposal.
Not the whole sentence though, right? Just
No.
the piece of it. Okay.
Any other questions? Any board members?
Is there, I guess, as long as we strike it, I'm good with that. Just wondering why that would add, why alliteration was added to it.
I don't want to pursue that.
Okay, we're good with it.
Okay. Motion to approve the minutes as amended.
So moved.
Second.
All in favor?
Aye.
Second point on our agenda is Nicole Singer with our financial reports. So, Nicole, nice to meet you again. Glad you're here.
Good morning.
Floor
Good
is yours.
morning.
Morning.
Hi, Nicole. You're nice.
The floor is
Can you
yours.
hear me?
Yep. Yep.
Turned it up.
Good. And can you see the financial report? Okay.
Yep.
And
Okay, great. So today we're going to go over the financial performance for February. Just kind of a quick update. We've spent the last couple of weeks working through a number of different projects on the financial side. So working through our charge master review, our pricing analysis being performed by iBailey. We are now just wrapping up our audit field work for the close of the fiscal year 2024. So that was last week in which they were doing their field work. We anticipate some additional questions over the next couple of weeks, but we'll be working to wrap those pieces up. And then we will turn our attention into the Medicare cost report for 2024. For the month of February, just highlighting what we've seen from the performance side, a gross patient revenue of $2.2 million. That is compared to the gross patient revenue that we had budgeted of $2 million. Deductions from that gross patient revenue then totaling $489,000. Leaving us with total operating revenue for the month of February at $1.8 million compared to our budgeted operating revenue of $1.7. Total operating expenses for the month of February came in at $2.1 compared to where we had budgeted at $2.1 million. And then our operating loss, we're left at $361,000 compared to the budgeted net loss of $508,000. Then when we flip into our non-operating, adding that into that bottom line, we have a net loss that we're sitting at $225,000 for February compared to our budgeted net loss for the month of February of $379,000. I'll jump then into the year-to-date with kind of January and February now. So gross patient revenue is 10% greater than our prior year. Our contractual adjustments currently are sitting at 21% compared year-to-date of our total gross revenue, and that's compared to where we ended the year 2024 at 20%. Total operating revenue is 3% greater than prior year, and total operating expenses are 6% greater than prior year. So when we look comparatively, right now we see that net loss on the operating side of $317,000, and then we have the comparatively to a net loss of at the same time last year of $110,000. So what, when we look at what's playing into that, we have some positive pieces here. We're seeing operations performing better than we had budgeted for the month of February. However, on a total basis, we're actually seeing we're trailing behind where we were prior year to date. And there are a couple of pieces that are playing in there. So a big one being our investment income. We see the market really took a drop at the end of February. for 2025. And so there's a large portion of that non-operating income that is playing into not having the same trend as we've had last year for that total net loss we're seeing. On the volume side, we see inpatient swing bed days totaling 103 for the month of February, and that's compared to our budgeted 44. Outpatient services, this includes our PT, OT lab, radiology, those are performing ahead of budget for the month as well by 13%. ER room visits totaled 208 compared to 173 that were budgeted, and the care center occupancy was sitting at 73.6% for the month compared to 74%. Year to date, we also see that our acute patient days are up comparatively to prior year, so 25 days year to date compared to 19 last year at this time. Swing bed days are totaling 151 year to date compared to 56 in prior year, so we see that pretty significant jump. And PT, OT modalities have increased 12% from prior year comparatively at the same time, and then home health visits year to date are 87 compared to 84 in the prior year. When we look at our financial indicators scorecard, we do see we've got a couple of red items here still. We do see it, we flip into the green for the net margin. So on the operating side, we're performing ahead of budget. On the net margin side, we're performing ahead of budget. Days cash on hand are sitting at 194. This is compared to our benchmark of 85, and also compared to prior month, we were at 197. Days revenue in AR, this is the net of our contractuals, is sitting at 62.6 currently for the end of February compared to prior month of 58.8. And our current ratio is sitting at 3.3. The debt service coverage ratio is also at 1.2 currently, and that is based on a rolling 12 months, so it is not just for the month end. For the financial forecast, the way that the organization looks at this is we take actual for the current year, so for the months of January and February, and then we also lay in what we had budgeted for the remaining months within the 2025 fiscal year. So when we set that projection, what we see is the total operating revenue is forecasted to be 3% ahead of budget. Total operating expenses in line with budget. And then income from operations forecasting to be a loss of $2 million for the year. And then a net loss for the year sitting at $440,000 within this financial forecast. This next slide shows us kind of the trend line here for this is our net, this is our total net loss. So when you look, the red line is that $0. We're going across the chart by month. The yellow line that you see here, this is fiscal year 2024 actuals. We also then have this blue line is the trend line for our budget. And then this green line, which we're just kind of getting into the year here, so it's kind of, it's hidden, but you can see that we're sitting in between that point of trending behind where we were 2024 on the total operating the total margin that we're seeing for the year. So that's operating and non-operating. And then this blue line, like I mentioned, is the budget. So we're sitting currently in between where we performed last year and ahead of budget. Are there any questions on this information?
Yeah, could
Yeah.
you go back a couple of slides to the KPIs for the month? Yeah, the indicators.
Yeah.
In the past, we've gotten kind of a view that has a rolling 12 months, and that's really helpful as we're looking at a trend,
Yeah.
especially the early part of the year. Would it be able to
Yeah.
go back to that?
So I don't have it readily. I would be happy to present
Well,
that
not
again.
this second, yeah.
Yeah, I would be happy to present that 12 months again. I wasn't sure from the standpoint of how easily you can see and digest this information in the meeting, so I wanted to get it as big as possible. And we've kind of flipped back and forth with that small picture and the 12 months. So I'd be happy to add in the 12-month kind of look back so you can see the color trends that we have over the year. But yes, I will do that for the next meeting.
Yeah, that'd be great, or maybe just 2 slides, because this is 100%
Yep.
much easier. And one follow-up question. So looking at days, accounts receivable, I think that we saw an improvement, if I remember right, from December 24 to January 24, but now we're seeing it go that other
Yeah.
direction, and just wanted to see if you had any kind of color to present to that.
Yeah, so when we look at, we actually kind of analyze it a couple different ways. So we're looking at hospital collections, we're looking at care center collections, and then a total. This number, it has a couple of, the number that you're seeing here is really taking our net AR and dividing it by the last 90-day rolling net revenue. So that the denominator in this equation can change. And so especially as we move into months in which we're not operating at our highest gross revenue level, what we see is the denominator often shrinks, and it can, even when your AR days stay steady, that it can play into your AR days. So what we're seeing here is actually our AR in total is sitting consistent with where we were prior month. Our care center days actually have come down a bit because we've been working some of those older accounts, moving things along within our system. So we do see a drop in total days on the care center side of about 10. The hospital then stays pretty consistent in total, and then our denominator has dropped because our gross revenues we're at a point in the year in which we're seeing those lower average daily the gross daily revenue that you see, that's that denominator. So sorry, did that make sense?
Yeah, I think so as it moved. I mean, my understanding of that metric, right, days revenue and accounts receivable, is how soon the organization gets paid back, right? That we get
Yes.
the money that we're owed. And so I guess,
Yeah.
however, that's how I'm
Essentially-
taking it. So as long as we're taking it in the right spirit, right, that's why I'm thinking that, yes, getting that number closer to that 45, I think, just noting, I remember what this looked like at the end of last year, and is there anything that we can be doing as a board to help support getting that trend line back closer to 45?
Without having the 12 months, as you had mentioned, we did see a pretty significant drop from about 70 into that 60 range in January. So the collections are moving. We're seeing collections, we're seeing positive outcomes. We've got a couple of different avenues too that we've been working on from the project side around statements. So from the board standpoint, I don't see a whole lot of opportunity in the sense of getting that back into, the 45-day range. It is really a function of us getting the take-rate agreement really integrated into our practice. We're having regular meetings with their team. So from the board standpoint, I don't feel that there's a whole lot that, we can do to push it into that 45-day range, but we are seeing positive trend back towards that 45 days that we're expecting. Do we see a little bit of the up and down right here? Yes. However, what I can tell you is from a total AR standpoint, we're consistent with where we were last month.
Gotcha. No, that's really helpful. Thank you.
Are there any other questions?
Thank you, Nicole. Looks really good. We're moving along here, so.
Thank you.
So we would like to have a motion to accept this report.
I'll move.
Second. All in favor?
Aye.
Next item on the agenda is old business. We'll start with the 2024 strategic plan, 2024 to 2027, pardon me, strategic plan update. We have materials in our packet. Any board members have any questions on how our strategic plans and projects are going? I know there's several in motion.
Yeah.
Lots in motion, really. So,
No, it's good to see that there's movement. The dates that we have kind of set to get some of this work done, we're meeting those dates. Looks like things are in plan to keep going here, and the staff is participating, so yeah, I'm pleased with the movement on this.
Yeah, it looks like everything's in yellow and green this month. Nothing's in red. That's great.
the question I had, on the scorecard, it talks about the new behavioral wilderness health, behavioral resource, services available. How's that going? I mean, is that what we were hearing, the document, the time? I guess.
No, no.
This is something else.
Yeah, we have a lot of different options and opportunities available to us. So the piece that we were talking about with regard to Evel, so we have the opportunity in the ED, if a patient comes into the emergency department for a behavioral health situation, we can get help immediately at that moment. With Wilderness Health, we have also been working with them that we often have people that come in with a behavioral health crisis.
Mhm.
We would like to be able to transfer them someplace, but we can't always do so because there's not availability, there's not an accepting location. So we can't just say, go home, okay? We end up keeping people. The concern with that is we're not really providing them with service. And so that was the question that we were talking to Wilderness about, is how can we provide service to people that we're keeping? And so what we had talked with Wilderness and what they developed was an opportunity. We have an hour a day for that's available to us if a patient comes in, and it's a weekday. That's part of the problem. It's a very specific time, so it's not like if somebody came in at 3 in the morning. So we have that if somebody's staying, they've been put on a 96-hour hold, those types of things. We have that. Also, what Wilderness just added, which we're excited about, is if a patient comes in and to the emergency department and they don't need to be transferred someplace, they don't need to be put on hold, but they need access to a behavioral health provider. Okay? They may not have somebody right now. And so what Wilderness has developed is that a person can actually make an appointment, a telehealth appointment with somebody that through that program, if they don't have somebody established. Or maybe they have an appointment with their provider, but they can't get in for another 5 days, those types of things. So we're able to get somebody support sooner than what we have in the past. So it has been utilized a couple
I was
times.
just gonna, that was my next question.
It has
Have we
been
done that?
utilized a couple times. It's not all the time, and we seem to go in streaks. We seem to have either a lot of behavioral health or not so much. But it has been utilized some. Haven't had the opportunity really to hear back, the response from those individuals that have been providing yet.
So early days.
Early days yet. But the ER component for the people that are here on the on behavioral health on a hold, that's actually really helpful because they're actually getting service and care and provide that. And those individuals have access. They actually are members of our medical staff and can make suggestions for orders. They can actually write orders for behavioral health and all those types of things.
Actually, I have one question after looking at these a little bit closer, if that topic's over. 2.4.1, we gave it a green arrow. It says annually invite state and federal officials to visit North Shore Health beginning 2024. The note here says that there was a meeting with them in St. Paul and an opportunity to meet with them in February down in St. Paul, but that doesn't sound like a motion to have them visit here.
We've invited them,
Okay.
but it's not,
So
yeah.
it'd be great if this one said then we invited them because it's making it sound
We've
like.
invited them, but that's not always the opportunity that, as much as I would love to always have our elected officials come in, spend time here and go through the tour. And by the way, we've had the opportunity to have Senator Smith here. We've had the opportunity to have Senator Hochschild here. We've had the opportunity to have Representative Scraba here. We've given invitations to others, but they haven't been here. But we also make it a point that we go to where they're at as well.
And that's all well and good. All I'm saying is that this says annually invite state, federal officials and aides to visit North Shore Health.
Then
And
we
it's
should make that
given a green
negative.
arrow.
Yeah, then we should
And
make
the
it
answer is,
negative.
we visited them in St. Paul. So I'm just saying from a clarity perspective, both are good. We
Yeah.
should maybe make sure that we're also
We should
visiting
probably-
St. Paul and doing that, as well as this one should be more aligned and maybe in the yellow so that we can back action on that. The one that comes right after it is well that we've invited, I think, Grand Portage, tribal leaders, city council, and Grand Marais to visit us annually. it would just be great, this one's yellow, I think appropriately, action hasn't started on it, but it'd be great to get that one kicked in the
So the
second
first
quarter
one
here.
probably should have been red then, so I will change that.
Any other comments, board members? Any questions? Pat? Let's go to our second point, under old business, board confidentiality agreement review. And we've invited Tim Feely from Paul Render. Tim is our hospital legal counsel. And he's had a chance to review areas of concern. And what I'd like to do is have Tim discuss some of the things that he's observed, and then we'll open it up to Q&A for the board members and discuss any steps that we may need to take. So, Tim?
Yes, good morning, everybody.
Morning.
I will pull the confidentiality agreement and just share it on my screen here. Can everybody see that okay?
Yep.
Okay. So what I'll do is I'll jump to, I think there were some questions about what some of the provisions of this document mean. I can talk a little bit about the purpose, why this is in place, but I'll focus at the outset, if that's okay with everybody, in terms of some of the concerns that I've heard regarding some of the language and what it means. So my understanding is most of the concerns are surrounded around number 1, which you see right here, number 2 directly below that, and number 3, all relating to what can be disclosed, what is confidential, what may board members do with respect to information in their possession, or certain types of information they may have been privy to because of their official duties as a board member. And I think that the general overriding concern I have heard is that this document, which has been signed by all board members, essentially limits a board member from talking about anything related to their duties, their participation as a board member of the hospital. And that is not the intent, was not the intent of this document. I'll speak to that in more detail after I go through some of these individual provisions. But just in terms of trying to be helpful, and then we can talk about maybe some of these individual provisions one by one. This first one, I'll just go through this, says subject only to federal and state law, including the Minnesota Government Data Practices Act, I cite to the statute there, in the Minnesota Open Meeting Law, again citing to the statute. I shall treat all written verbal information received as a board member in the strictest confidence, shall safeguard this information, and shall not share any such information beyond the board, the officers, legal counsel, without the approval of the chair of the board. So what this is intended, and the way I wrote this, to be clear from a legal standpoint, is that unless the information is publicly available and subject to disclosure by the organization, then it should, absent that, it should be kept in confidence and treated as confidential information. So, and that was the purpose of this initial sentence here when we were redoing the confidentiality statement. Sorry about that. This was intended to mean that subject only to. So if it's publicly disclosable, it's information available to the public. Traditionally, or I think historically, you would see that in terms of a response to a request under the Minnesota Data Practices Act. If it's disclosable under that act, you know, you also have to think about certain federal laws here because of your status as a Medicare participating hospital. But if it's publicly available information because it's not precluded from disclosure under these authorities, then it can be disclosed. Obviously, this means that, and I think we've talked about this before, if you follow the statutory scheme that applies to public entities under the law, information, definitely written information, should be disclosed pursuant to a request made to a responsible authority, which can be somebody designated by the board. Alternatively, in the absence of a designation of that person, it would be the secretary of the board. But in this case, the hospital has disclosed and/or appointed the CEO administrator to be the responsible authority to ensure compliance with the Data Practices Act. So at any rate, that's the intent of this. Maybe we can stop there, and I can take any questions that anybody has about that, but that is the intent and the way this was written and what it was intended to mean.
Am I to understand that the intent then is to restrict as much information release as possible, since the only thing we're allowed to release is what is specifically releasable under these particular statutes? Because that's the way this reads to me, and treating all written and verbal information as a board member in strictest confidence, when I read that, I would say, you know, I can't even tell anybody we had bagels.
And that was not the intent. I think, I mean, there's a couple of dynamics. Is that Dr. Schmidt?
Yes, I'm sorry, it's Dr. Schmidt, yes.
Okay.
And-
Yeah. No problem, doctor. My screen is minimized, so I can't quite see everybody clearly.
I
So,
should have announced myself, I'm sorry.
I think there's two dynamics at work here. One is under either the Open Meeting Law or the Government Data Practices Act, the law would presume, I mean, the law starts with the presumption that everything is public information subject to disclosure. But that's a little bit confusing because then the statute goes on to identify all types of information which is accepted from that, which includes, and we went through, I think, some of these during that training session that we had in January. But for example, that would be any private or confidential information, obviously patient information, certain types of contract provisions may preclude disclosure that should at least go through an analysis to see whether or not they can be properly disclosed. So there's a number of variables here just under state law. And then the other dynamic is obviously as a healthcare provider and a Medicare participating hospital, all of that litany of federal laws that may apply to the institution as a result of being the hospital apply as well. So it definitely adds a number of additional layers. So me, when I read this, and maybe we can talk about how this could be rewritten to address your concern, to basically say the same thing, or to recognize the principle that as long as it's not precluded from disclosure by federal or state law, then it's publicly available information.
Tim, can I ask real quick?
Yes.
Yes. If the intent in number one is to reinforce the existence of state and federal guidelines around confidential information, why add in anything else other than you are subject to these laws and statutes?
Sure, that's a good question. Two things I would say about that. One is It is a best practice, and by that I mean and the intent of this document, and it was the intent of essentially the training that we provided back in January, is to be able to show to us something along that lines where the hospital is called upon to explain why certain information was disclosed that should not have been disclosed because it was covered under an exception under federal or state law. The first thing the agency is going to want to know is whether they're going to want to know how members of the organization that had access to that information were educated by the organization to try to preclude wrongful disclosures or mistaken disclosures. And that would include, typically the request is for training materials, any statements or obligations in writing that may apply to the use of that information by the organization. That's the first thing that they're going to want to see by virtue of, if it's from the federal government, what's called the civil investigative demand, by the state, either by document request or even a subpoena by the Attorney General's office. And so this is the information, we believe we need to have to be able to show that, yes, whatever mistake was made was unintentional, it was not made in bad faith, and hopefully, in terms of the second item I talked about, hopefully that information and what it's intended to do as well is try to mitigate the mistake to the federal or the state agencies so that we can show we took all of these steps to try to avoid this. This truly was a mistake. Yes, obviously it occurred. There isn't going to be any dispute about that. But it clearly shows also that the organization had safeguards in place to try to preclude that mistake or that disclosure from happening.
Tim, respectfully, I don't think you've really answered the question. You've talked about the training we received, which we had a 2-hour presentation from you in January. We've had other trainings on governance and how to follow laws. We've been at the Minnesota Hospital Association annual meeting in which they've done the same thing. And so I think that the hospital has ample coverage to say the board members are acting in good faith because they've had all of this training. We've made it available to them so they understand what HIPAA and confidentiality clauses are. They understand the state statutes and federal statutes. And this document doesn't say any of that. It just says these exist and the individual accepts responsibility for all of it. That's how I read this. Nothing that you said about training and making sure that we know what our role is in this document at all. That's all covered in other material, our bylaws, and other agreements.
This is Dr. Schmidt again. I can't get past this treating all written and verbal information received in the strictest confidence. That clearly, on the face of it, says absolutely everything that has anything to do with the hospital. I am to treat that in strictest confidence. I have no problem with obeying HIPAA, with obeying all of the other regulations that are required. I've been doing that for 45 years. I have no problem with that. But I do have a problem with this particular approach to minimizing the amount of information that we can release. We should be maximizing the amount of information we can release, particularly if we're going to try and communicate with our with the people that we're trying to serve.
So would you feel better about this? So first of all, and I understand that there is some disagreement with this. Just from a legal standpoint, my recommendation is that this is an important document that should be in place that decision obviously is for the board, not for me. I can only make my legal recommendation, and so it's up to the board in terms of whether or not they want to have a document like this in place. But so I think Sam said he doesn't want the provision at all, and you don't like the way it's, or you have a question or concern obviously about the way it's written. What if it said, I shall treat all written and verbal information that is precluded from disclosure under federal or state law, including the Government Data Practices Act or the Open Meeting Law.
To be honest, Tim, I have a problem with this entire document. And the reason that it exists, you've assured us that it has, that it's best practice or it's in the best interest of the hospital. I don't really see how that works. I've thought about this a lot, I've contemplated a lot, and I could have a lot to say about this. But I think if you're going to ask me about various provisions and whether I want this provision or that provision or the other provision, my answer would have to be, I really don't want this document. And if I think we have an acknowledgement of confidentiality, which is what's required in our bylaws, I think that should be sufficient. And I think anything else is merely opening ourselves to potential problems and litigation. I think it's going to minimize the amount of communication we can have with our populace. I think it's going to, actually I think it is contrary to the vision, values, and mission of this organization. When we are this restricted in what we're allowed to say, we cannot follow our mission and values, our values in particular. How do we do service excellence when we can't talk to people? How do we collaborate when it's impossible and one party is working under threat of litigation? And we'll get to that at another point. How do we enhance communication? How do we, all the legal restrictions that we're placing are counterproductive to improving our public opinion and our communication with the people we're trying to serve. We're working on CQI. We want to get CQI. We want to do continuous quality improvement. We're doing a great job with that. But we can't do that if we can't talk to people. We can't do that if people don't feel safe, if they're under threat of litigation. And if we're going to talk about just culture, we have to have people working in a safe environment. And I think having the board afraid of being individually sued and personally liable is a terrible idea. I can see no positive nature of that at all. So I think this agreement doesn't promote our missions and values. I don't think it even permits it. And I think we can rely on the understanding of confidentiality required by our bylaws. We already have guardrails of HIPAA and other laws to restrict us appropriately, and we need not further restrict ourselves.
Hey, Mylan, I hear what you're saying, and I hear the frustration. I look at this, and I don't have a problem with it, because I'm looking at how the world has changed. And people can say whatever they want. They can end up suing you for whatever reason. This to me is a protection not only for the hospital, but for me as a board member, so that I can do what I'm supposed to do, share the information that I can. And I don't feel that this is restrictive. I look at this as being protective and making sure I'm not talking about personnel stuff that I can't, or medical things with patients. And to me, this is just an added layer of protection, not only for myself, but for the organization. And I talk about stuff all the time. I don't feel restricted at all.
Then what do you talk about? What do you talk about the board that doesn't happen in this open meeting? Nothing, according to this definition.
I talk about the advances that we're making. I talk about how we're doing with meeting our obligations as far as keeping our doors open and what we're doing is promoting staffing. There's all sorts of things that I can talk about.
But not, that is information that is garnered by virtue of verbal or written information that you have received as a board member. Is it not?
Well, I guess yes and no, but I don't take it as being restricted.
Well,
But Patty,
then
I'm
you
sorry,
are
my
opening
only-
yourself, in my opinion, you're
Okay.
opening yourself to legal action and to being censored by the board for releasing information that is confidential. Because this defines anything that happens in the board as confidential information. I was kind of tongue-in-cheek when I was talking about the bagels, but technically, that is true. That is information we only know because we're here. So we can't even talk about that, the way this thing is written.
Yeah, let me interject here. That statement, respectfully, I would not agree with because, like I said before, if it's publicly available,
That
Under any
information,
of
how
these-
is that
under-
information publicly available, what Patty just said? How the hospital is achieving its objectives?
say that again.
How is the information, specific information regarding how the hospital is achieving its strategic objectives, how is that Patty has learned, as her role in a board member, say in a conversation amongst the five of us? This says all written and verbal information.
But you're ignoring the first part of the
It
sentence.
doesn't matter that it's there, though. It does not matter that it's there.
Well, yeah, I would definitely disagree with that. I mean, that's very clear from this paragraph. Maybe if you're misunderstanding it in terms of that sentence not being there, I'm not sure. I mean, clearly, if it just started, I shall treat all written and verbal information received, and it was that one sentence provision, I would wholeheartedly agree with you, but given that it's subject to federal and state law, including the Data Practices Act and the Open Meetings Law, if it's publicly available information under those authorities, then it's not confidential information because those authorities would say it can be disclosed.
See, what happens in this, when we state the statutes tells us what we can and can't share. And we don't write that all out. I mean, that would be a lot of paper, but we can go and read that. And if you read that, we can just about talk about everything except what's in the closed session. That's what I'm saying, and that's how I'm
This
interpreting it.
document creates a tremendous amount of confusion. The other point that I would have is if we are, there are certain things that are precluded by the state law, and there are certain things that must be available according to open meeting law, as I understand it. Is that not correct?
There's certain things that are.
Certain things that we're not
please.
allowed to talk about, and that's primarily HIPAA, and there are other things that we are required to be able to provide information on, and that's open meeting law in general. I'm no attorney, so, bear with me here, but that's my understanding.
Okay. I would say that's generally true.
Okay.
I mean, there's information, for example, the board packet is available as long as it doesn't contain any closed session information. Obviously, you just saw a presentation on the financial information. That's obviously public information. Anything discussed during an open meeting is obviously public information. But you're also right that there are things that are prohibited from disclosure.
It seems to me that as a general principle, what I would like to see is for us to be as open as legally possible, not as restricted as legally possible. And the way this whole document reads, to me, we need to be as restrictive as possible in releasing information. That, to me, is counterintuitive and counterproductive.
So Mylan, from your perspective, looking at this document, obviously stated your opinion.
Yes.
Do not care for it, and would like to do what? Revert back to, we just follow HIPAA, et cetera, and state guidelines, and leave it as that. What would be your way forward if we took this document and modified it to maybe be clear on, to anybody who reads it that says, yes, I can discuss this, no, I can't discuss that. What's your opinion?
My opinion is that the acknowledgement of confidentiality that we have should be sufficient. That is my opinion.
So there's no other alternative?
I am not going to preclude other alternatives, but it doesn't seem to me that we need to further restrict our ability to communicate with with the public. Not further. Now, I know we have to restrict. I know we can't talk about, personnel matters. I know we can't talk about patient care matters. I know we can't talk about business secrets, all of that stuff. I know that. But why do we want to further restrict that, which is what we're doing? And the other significant thing we haven't talked about is this idea of personal liability. If there's a clause in here about we are personally liable.
Yeah, this document doesn't create personal liability. That potentially can exist under state or federal law. This document is not creating that where it doesn't exist. That may be, depending on what the disclosure is and what agency is handling the complaint. And there's always going to be organizational liability with respect to any unlawful disclosure of information, say for example, individual private data. But there could be personal liability as well. This document doesn't create that. It acknowledges that there's an understanding that can occur under the laws that would otherwise apply as written.
So, Tim, it's my understanding, if you look in our bylaws, that we as board members are indemnified, meaning should somebody slip up, should somebody share a piece of confidential information because it was written on a Post-it that got stuck to the bottom of a shoe and somebody saw it and they sued the hospital, that the hospital would say, yes, that board member is responsible for that action. HIPAA was broken in those ways, but they acted in good faith. They were trying to throw that Post-it away. They were writing the information down. They put it in the correct system, let's say, or any staff member, that you will, as the council, the hospital, support board members or an employee to say that wasn't their intent. Their intent wasn't to break it. Here's all the things we have in place. But what this says is that that goes away. And if ruled against you in this, and also that this needs to be in favor of the hospital, that you are now liable for all costs, including the legal costs of the hospital. This doesn't protect at all. And it gives that up.
Yeah, I don't, I guess I wouldn't, obviously I respect your opinion. I wouldn't agree that that's the case. I think the bylaws say, and I can pull them up, but it basically says that you're entitled to indemnification. Any individual board member or officer is entitled to indemnification from the organization for any action within the scope of their official duties, in good faith. And so as long as there's not any bad faith, indemnification will be available. So it does state that, and the reason for that is just public policy would say that an organization should not agree to indemnify one of its officials, a public official, who's acting in bad faith. That's not fair to the public, because basically what is being used to indemnify that public official are taxpayer dollars.
But it's not a court that gets to decide bad faith according to this agreement. It says that anything shall be construed in favor of the hospital, that the hospital
It
gets
is,
to decide
it
who's bad faith.
it would be for a court,
Exactly.
depending on the
But I think
circumstance.
our point, as Dr. Schmidt said, and that I would agree with, he has brought up, we should seek to be as open and transparent as legally possible, not as restrictive as legally possible. And the fact that this document exists at all, when all the things it's claiming to safeguard against are already in our bylaws, which were just updated. I believe you were the author of that as well. To me, seems like a document that, as I would agree with Dr. Schmidt, should be voided. I'm open to conversations about what a new document might look like. I'm open to signing the confidentiality statement that just says I acknowledge what HIPAA is, what confidentiality is required in our bylaws. But I do believe this entire document should be voided, and we need to start fresh.
Steve, do you have any comments?
Yeah, I teeter in the middle. I find it frustrating. The confidentiality is frustrating. Anyway, even the legitimate part of it, if you want to try to make a point to somebody, and you know you can't. But there's always that, so what am I going to say? Where am I? In the middle of it. So I probably say less, because I don't, because I know I've already, so it seems in one sense, I mean, this is just my hypothetical that's coming to me as I teeter here, is if we simplify this form, maybe go back to the old one, or maybe I'd amend that one slightly, but then have a kind of a guidance information that we don't have to sign off on as much as have as an example of how can I be responsible to the confidentiality, and what can I say, because I know stuff that's interesting to the point that I can't say. I mean, I can't bring out, and I do understand some of that. I mean, I just maybe something that's clarifying for precision, and even documents in our total. I mean, I sort of appreciate Jim's point of view about if things push comes to shove legally, what have you done as an institution, and what to keep. So I mean, I think there's good points on both sides, and I would just sort of favor breaking it up and clarifying it, simplifying the one form, but educating on another form that's not quite as legalistic as much as just even examples like how do you fall down on this, how do you navigate that line? For me, it's very important. I mean, I've been in this board for just a few years, and it's been frustrating to try to. I see stuff in the letters to the editor, and I see people's opinion about stuff that is based on the information that's public out there on stuff and not what's private. And I think there are almost myths floating about out there that aren't true, and it frustrates me, because yeah. So I mean, it's crazy, and it's not very surgical.
Being a surgical guy, right?
Yeah. I have worked in surgery for many years. It's not surgical.
It's not surgical.
At all. But I'm really floating in the middle.
Yeah, and, you make a good point as far as understanding this, what can be disclosed, what's not disclosed, etc. And it does get confusing at times. I think we all understand that.
But not only gets confusing, it does get frustrating at times.
At times, yeah.
Well, one thing this agreement does is it makes it less confusing, because as far as I'm concerned, it means I can say nothing. So that's not confusing.
So good point. That's your interpretation, and
That is the interpretation of anybody who would read that sentence.
That's
the
the interpret-
wording here is, to me too, I mean, like, wait a minute, what about, what do you mean quality information, statistical data, strategic, that stuff's, like, we can't tell anybody, not, I know it comes back probably to say, well, it wasn't precluded, but, how we're doing really well. I just heard about these things in this committee I was in, and, like, I can't tell anybody that.
About quality ninjas.
Yeah.
Can't tell anybody about quality ninjas, come on.
Yeah, I understand.
That's a cool idea.
Yeah. There's so much good going on there, and I feel like, can I even tell anybody I'm on this committee? I audit, I mean, I don't produce the information. I'm there watching it. And they're doing a great job. They're doing a great job. The leadership out there are doing things to improve what's already a good hospital and solve problems and and I can say that out loud, but I might want to say, there's probably things I wouldn't say out of there. So it is my responsibility to be smart about data that's being presented that might imply something different if the full thing wasn't known and so forth. I'm getting redundant.
No, that's totally fine. No, appreciate that. So here's where we're at.
Could I ask Randy, because I've gotten the impression that you're much in favor of this agreement. Could I hear your perspective on why you think this is such a good idea?
Well, two things. Number one, it does go into some detail about the types of
Excuse me, Randy,
information.
could you put your microphone closer?
Sorry.
Thank you.
It does go into detail, as Tim had mentioned, on the types of information that, as you can see under number 2, such confidential information includes, but is not limited to, employee, patient, quality, statistical data, strategic discussions, etc. It does not, however, include any such information that would otherwise be publicly available. And that's reiterated throughout this document. So that's number 1, that we're not precluded from releasing any such information that is otherwise publicly available. And that would be under the Minnesota Data Practices Act, etc. Is motion there. The second thing I would say is that a separate and distinct document for board members is quite common throughout the healthcare industry and private industry. So I don't see one document as being the be-all and end-all for everybody within this organization. And the third piece here too is as I'm hearing everybody talk about this, as we rely on legal experts for this type of information and to create documents and help us develop policies that, number 1, protect the organization, because if the organization does not exist, the mission does not exist. So that's number 1. Number 2, protects patient information. Private patient information in today's world, I won't even go there because it's a bit scary. And number 3, it helps the board to understand what their true role is in interacting not only with management but also with the public. So I would suggest is that we take this document and run through several iterations and see if we can come up with a document that is maybe more understandable for everybody. Steve's point is very good, well taken. Maybe there's some ancillary information we can create that would help guide our understanding of our roles and responsibilities. So that's my opinion.
Okay.
That's my opinion. That's
Clarification, Randy, how does this protect the board, in your opinion?
because it gives the board detailed notice of what you can and cannot talk about.
I respectfully disagree.
That's fine. That's fine. We can have these disagreements. That is my interpretation and understanding of this document and of this policy. That's my interpretation.
This is an okay time. I would like to offer my interpretation of how we got to this point. I do want to say, Randy, I completely agree with you that we need to rely upon subject matter experts like Mr. Feely, like Jason, like Nicole, like Kimber, like Greg. However, we also need to rely upon a varied amount of those perspectives. And here we have one perspective that has been given to the board, which is that of Mr. Feely. No other legal perspective. Some of us have gone out to seek our own legal perspective as individuals because of our worry about this and what it does to our community. So yes, we have one person's legal perspective on this, but I think we also need to take into account how we got to this point. And I really want to thank the community members for being here because we appreciate the time in the middle of the day it takes. This is a really challenging discussion, but it needs to be approached with the same openness and commitment to good governance we've talked about. There is trust between this organization and community that has been a long-standing concern. And so to put this agreement in place in the way it is, at the time it was put in place, which happened just a mere month, or actually a few weeks before the election, when Dr. Schmidt and I were elected. Yes, it was emailed to us on December 28th, but it was labeled as a confidentiality statement, which our bylaws say you have to make a confidentiality statement which just says, I understand what confidentiality is. That seems appropriate. At the meeting when we were being sworn in, it was put in front of us and this was the document that said agreement. I sought clarification and was assured that this was routine. Now, while we have to sign this agreement, as you said, the hospital administration is not subject to this agreement. I agree with you. We should have different agreements for each time and place, for each role, for each situation. However, the limits that this puts on in terms of who gets to decide as the hospital that somebody has broken it, 5 of us don't get to decide that. There's only one person who does, and that is, I guess, the hospital, who the decision makers would be the administration. Now, and I wrote these down because I want to make sure my words are clear. This isn't how governance should function. This board exists to oversee and support the administration, not be controlled by it or by the hospital's lawyer. This agreement, as I said, significantly limits transparency for all of the taxpayers who are here and the ones who aren't. It has this far-reaching language that has all of us wondering what it truly means, and the only clarity we can find are in the statements that are all-encompassing, like all. So I really urge us to void this agreement entirely. Again, I am absolutely open to signing the confidentiality acknowledgement that exists in our bylaws. That was fine before. I'm open to having a group where we sit down and we say, what should this look like for board members? Because I agree with you. Maybe there does need to be one specific for that. But voiding this restores transparency and it benefits the taxpayers of Cook County. To keep it in place only benefits the hospital administrator. Now, our legal counsel confirmed this agreement is not required by law. We've heard Tim say this multiple times, that it was there to reduce risk. This all increases risk for all of us as board members. We've talked about the bylaws requiring a confidentiality agreement. We've talked about indemnification, right? And even the line in here that guarantees a one-sided ruling. It says, I agree that it should always be ruled in favor of the hospital. Now, to govern well is to lead with integrity. And right now, integrity demands that we return stewardship to those who it always belonged, the citizenry, via their elected representatives, us, the board. We were elected to represent the people of our county and in their districts, not to serve as a rubber stamp to this administration. Let's reaffirm that our commitment to ethical open governance by passing a motion to void this and working together to create the right agreements for the right role at the right time. Thank you.
Patty, any comments?
I hear what you're saying. Parts of it I agree with and parts of it I don't. We are the hospital, know, we're in charge, we're everybody's bosses here. So this to me protects us, and if it protects us, it protects the hospital. I think we can reword this, but I'm sorry, in this day and age, and how people are so happy, this not only protects the hospital, but to me, it's another layer of protection for our individual board members. And I think as we ask people to run for office, and it's getting harder and harder to find people who will step up, I feel you have to have protections for them, to know that they're safe, to know that they're not going to be sued. You know, people can say anything, and we've got a digital, day and age out here. You can manipulate things, you can say whatever you want, and because we are representing the board, if I take offense individually, I can't go and confront that person. I'm limited to that. So you gotta get a tough skin. You gotta take things, and I appreciate another level of protection, not only for my safety and the safety of the members on the board, but for the hospital as a whole. So I get language, and if it's not comfortable, this can be reworked, but to totally get rid of it, I could not support that, I'm sorry.
So Patty, I hear you saying that this supports you.
Yes.
One thing I want to be clear though is, and you brought it in, which is the agreement for you yourself that you signed to serve at the Ogish School Board.
Mhm.
It is nowhere near as restrictive as this. And your purpose in bringing it in was to say, hey, this is similar. Last time you said that.
Yep.
All of us serve on various boards. None of the confidentiality agreements are this restrictive. Now, this is a hospital with PHI, with PI and confidentiality. And honestly, of any two people who I think really understand that incredibly well here, that's Dr. Schmidt and I, since this is the area we work in.
I would disagree.
I disagree with that.
Okay, you can
You think
disagree
I
with
do
that all
not
you want.
understand
No, I would
confidentiality?
disagree that it's only you and you.
No, I didn't say you don't understand
Not
it.
all-
I think
No,
we
you said you're
understand
the
it.
ones that best understand.
So I think there's a darn good reason to believe that if you look at our
Carry
professional
on,
record.
carry on.
I would like to carry on. So the other thing, I agree with you, Patty. Let's say there's an AI video out there and it shows you bad-mouthing Kimber. I think many in this community would go, that doesn't look like Patty. We haven't seen her doing that before, but man, it looks really accurate. Kimber gets pissed. Kimber goes to Tim and says, I need you to go and sue Patty for defamation. That's how quickly this gets out of control. Only the 5 of us can be sued in that way. If there's a video of Kimber doing the same thing, we can't do that. We have signed an agreement that basically says, you get to decide that. And as a person who works in digital healthcare and data technology, I'm telling you that that is really how this is. All I'm really asking for is to void this agreement again and have a conversation amongst all of us in the open public. Have a committee of the whole. Have this discussion for what we need. But we also need to look at this more than just this agreement. It's not about us. This community has only showed up in mass when this happens, when it shows that we don't trust them. And this is another way that we are showing this community that we don't trust them, that all of the information needs to be held within us. You are not to be trusted with anything, even if it's publicly available. It says it right here, all information.
We're interpreting things a little different. It's just
I think it's
a
sort
different
of
way to
I
look
think
at
it's
it.
fuzzy language that can go either way.
I agree.
But I agree,
Yeah.
what you said was absolute, and I'm saying it's just, it's tricky language, and I believe.
That's a great
I
point.
agree
It's
that
very
we
great.
need-
Yeah.
We need to rebuild something that would meet these. all these
Maybe what-
concerns.
Wholeheartedly
I
agree.
agree with that.
I absolutely agree with that too. Thanks.
Maybe what we need to do is do a subcommittee of people that would like to work on this with our legal and come up with something that is more palatable to everybody, that kind of meets the needs. We're not gonna get a perfect agreement. This will stand for now, but things always change. And the reason that this changed is things evolve, you know, the world's changed, and so you have to adapt, as we all agree. Our agreements and what we sign needs to evolve and adapt and address the environment that we live in. And I thought this had done this. I understand and I agree that there is some language that's, you know, maybe restrictive or a little iffy. And if the board as a whole can't agree to this, then okay, let's develop something better. But I, for one, appreciate a separate confidentiality agreement. They tend to be standard, and you work in businesses, you sign stuff like this. I would personally like the protection not only for the board, the hospital, but for myself personally, and that's where
Respectfully, no business gives this hospital $1.8 million a year right now in a tax levy. We're asking for their trust.
See, I feel we have their trust. People show up, people talk to me. I don't feel that people don't trust.
Well, then
Do
you're
they
not
have
talking to the
issues
same people.
sometimes? Yes, but do they trust? Yeah, I think they trust.
So we can stay here all day and do this. What I'd like to do is have a motion to amend the agreement and to create a subcommittee to work on that with Tim Fielding.
I'll move.
We have a second?
Yes, sir.
I will make a motion that I would like to void these agreements for all 5 of us as they are today. We can then discuss either I will sign today the same acknowledgement statement that was required before in our bylaws. We could do that, all 5 of us today. And then also create a subcommittee, as you said, Patty, to say we do need a separate agreement that we will look at. But I really believe that one way for us to move forward as a community, for us to move forward with clarity and intention, is to void this agreement.
I would second that motion.
Wait, so what, you have 2 motions going now, so.
No, there was no second
There
for
There's
the
no
first
second
motion.
for the first motion.
So that
it
motion
dies.
doesn't exist.
Okay, I did not hear that. Okay,
Dr. Schmidt seconded my motion. I would like a vote, please.
but you need to have discussion, if there's any discussion.
Let's discuss. Anything additional?
I think that's probably a good idea, but I am stating that we need a separate agreement. And if we're gonna follow through with this motion to create a new one, then I can probably see voiding this, but we need a separate agreement. And I think, you know, if we need to change the language, okay, but not to have one, I am not in favor of that.
I would actually appreciate what you have said before about maximum protection for the board. And I think if we look at the confidentiality of changing a new agreement, that would give us additional protection, because I'm definitely in favor of that. You know, I think we do need protection. The way I read this jettisons all my protection. So whether it's just a language that I'm misunderstanding it because I'm not an attorney and blah blah blah, I understand. Okay, fine. But then let's get an additional agreement that we can actually agree on that gives us some additional protection, while preserving our ability to build trust, to fulfill our values, to be to manifest, to lean into the hard work of rebuilding the trust that I think we have lost. And the last part of that was editorial, but I think I would agree with you that we need, if we're going to have an agreement, it needs to protect the board, not further jeopardize the board.
So the motion as it exists involves negating this newer document and creating a new one. Is that
That's my
right? Those are
understanding.
both factors that was, I don't recall all the works done.
So
Asking
instead
that for
of, that's a
clarification.
good clarification, so you're saying, so instead of going back to the confidentiality statement that existed before, to create a new confidentiality agreement for board members?
Well, we can sign the old one if we feel we need to cover ourselves
Yes.
before we make it better.
Okay.
Does that make, I mean,
That
I'm
makes
just trying to,
sense.
I'm not.
That sounds
I'm
good to
not-
me.
Yeah.
Yeah.
Point of clarification, we're talking about a committee to do this, and somebody said, those who are interested, and somebody said all members of the board. If there's more than two of us, then it's an open meeting, as I understand it, correct? Correct. Okay, so,
Now, wait a minute. If we're having a subcommittee, Tim, you'll have to weigh in on this. If we're having a subcommittee of a couple board members to work with you to reword this, that doesn't need to be open meeting law. That's a subcommittee to do some work. That's a working committee where they would work, or whoever would work with you to recreate this and then bring it back to the board, to present it to the board, and then the whole board would vote on it or make any other amendments or changes to it that they would want. We can do that without doing like an open meeting. We're not bound by open meeting laws to do that, are we? That's the question.
So we need to talk about that a little bit more. I mean, I think the number of members, and as long as the committee wouldn't have any decision-making authority, it would not be acting on behalf of the board, but just purely making a recommendation to the board, then it may be able to be done without noticing it as an open meeting of the organization.
That's what I'm interpreting it to be, and it would be, in our minutes that we, if we decide to do this, that we got rid of this one, and that some board members are gonna step up to the plate to work with you to do it, to develop and do a recommendation, and they will come back to the board at a different date and present this, and we'll look at it and take a vote on it as a whole board. If that's, legally, I think we can do that.
I'd agree.
And I can check, yeah, and I know there's something in the bylaws too, I believe, in terms of subcommittees of the board.
Yeah.
I think that's addressed in the bylaws as well.
actually, I didn't see it addressed in the bylaws because I was looking ahead in the agenda, and I thought, subcommittee, what's a subcommittee? Let me look at the bylaws and see what a subcommittee is. And that doesn't actually mention subcommittees, so.
This would be a committee.
This would be
a
a
working committee or
Yeah.
something.
So-
Yeah.
I did not see that clarified in the bylaws, so you're the attorney, your interpretation goes.
I think this is important enough, though, that we have quality committee, we have medical committee, we should have a finance committee, we should have a committee of this.
Yeah, we fall under governance. So my comment is, that, maybe to make things simpler, is not to throw the document out, but to modify the motion to create a committee to review the document and make changes where we deem appropriate, along with our legal counsel.
I don't think you can just change a motion. There's a motion on the table that I've made, and that motion is seconded,
That's-
right?
Well, I'd like to amend the motion.
We don't have any language that says anything about amending a motion in our bylaws.
Okay, can we do it this way? This goes back to civics
I mean, if we
101.
go back to discussion, I guess I would say I personally disagree. I don't think that should be the motion. I think that we should start from a level playing field, right? We should start with a new document so that all of us have equal understanding as to what that is.
Yeah, it's half a dozen of one, half a dozen of another here. I mean, it's just,
No, it's not.
No, it isn't.
Well, okay. All right, well, okay, we can disagree about that. I think this is the working point, this is the point to jump off and fine tune, because if you go through all of it, it talks about, like, more specifics, but,
All right, my 2 cents worth.
Sure.
Is that, if we nullify this, then the committee can still use this as a document to inform
Sure.
it in its deliberation.
Absolutely.
Yeah.
But it's currently, we're killing it. I'm not sure where the fact is that we've already signed it goes, but we'd like to think that, this is effectively doing it, and we can, this is all data that can be utilized to recreate.
Yes.
So,
Call the question.
Well, and then the other question is what we sign, we've signed a couple documents, are we covered with the other document? That's legally, are we covered?
Which document are you referring to?
The other confidential, the one that you're talking about.
The confidentiality statement.
Yeah,
no,
yeah. Does the statement
They
cover us? in the
Neither one,
meantime?
actually, neither one has to exist. I just want to make that part of it clear. Our bylaws state that this one has to exist.
This
An
is the old
acknowledgement
one,
of
acknowledgement.
confidentiality. So the bylaws state that has to exist. So I guess I would fix what I just said, clarify that yes, we do have to sign this one actually, or some statement. I think technically it could just be that I understand what section 3.11 is. But that's why I'm saying I'm comfortable signing that because the bylaws were publicly available, easily read, and I read them multiple times before personally deciding to run for this position. And so I am more than comfortable to do that. Steve, I think that's a great point, which is it doesn't mean that this other agreement we signed, that the words on the page, I mean, legally they don't exist, but from a knowledge perspective, yes, we can look at it and it will certainly inform the conversation as we move forward.
Yeah, because I'm saying you don't have to reinvent the wheel. I mean, the wheel's already invented out there, and there's several forms of this wheel, and I'm saying, as we move forward, or whoever works on this, this is gonna be extra work, and that's fine, but there are good documents out there. We can build and modify them to feed our specific needs and what makes us feel comfortable and able to do our job here. I don't know that you have to just say, because I disagree, I don't think this is a bad document. I think it needs to be better worded. I agree with you on that. But, yeah, my premise here is I want to be covered in between until we get something new or better, because I think it's important.
So I'm more than happy to say that my motion would include that we sign the confidentiality agreement that was in place beforehand, and then we also establish, we void the current agreement that we've signed, confidentiality agreement. The 5 of us sign the acknowledgement of confidentiality as required by the bylaws, and then we form a committee that will seek to make a recommendation to this board for what a confidentiality agreement for board members should look like.
So you'll have to withdraw your original one and then restate it with the second motion.
All right, I will withdraw my first motion that was seconded by Dr. Schmidt. I will now restate the motion. The motion that I am putting on the table is that we void the current confidentiality agreement that the 5 board members have signed. We then sign the acknowledgement of confidentiality that is required according to our bylaws and the one that was signed by previous board members. And we then create a committee that will give a recommendation at a later date to this board about what a new confidentiality agreement should look like or contain.
I will second that.
Seeing the vote? All ready? I'm in discussion? I'm sorry.
With working with our legal counsel. We pay Tim to do this, so we need to work with Tim to come up with the.
What do you mean by that? What are you trying to cover?
I want to make sure that legally, we've got the legalese in here, that we are protected and that we are adhering to the federal and state laws.
I completely agree, but I guess I would also say that, as I've said, we're going to need multiple subject matter experts to help us come to this, whether that's also Tim, whether that's Matt Anderson, who came and gave the board direction in February, who I think was well received by all of us. I think we need more opinions on what an agreement like this should look like. And so I don't want to restrict it to what Tim writes in any way, and we keep looking at his versions of it. The hospital legal counsel 100% should be involved. If anybody
All right.
saying they should.
So that's implied.
Okay?
Any other discussion? All in favor?
Aye.
Aye.
All opposed? Motion passed. We'll create a subcommittee.
Inappropriate.
No,
It's inappropriate.
that leads to the fact that you really just don't understand this is about trust and not about yourselves.
You know, I'd like to take a break.
Okay.
Yes, please.
Yeah, take that.
Steve, thank you. Very well said.
Oh, it's
I
affordable.
hadn't thought about some of those words.
That's how I feel. This is satisfying, right?
Yeah. We're taking a break?
Yeah,
That's good.
break.
All right.
We call it a bio break.
Bio break.
We're going to move on to new business. First item under new business is governance mentorship. And I'm bringing this up as a recommendation to the board to consider engaging someone like a Matt Anderson as an independent mentor for the board to give us an objective opinion on, first of all, how we're relating to each other and relating to the community. Secondly, to see how we can improve or enhance our ability to govern effectively. And the reason I bring this up is all five of us are new in these roles. Mylan, you're new. Sam, you're new to the board. And drinking from a fire hose, obviously.
Especially on governance.
Yes,
Yeah.
governance, yes. So that's the concept. It wouldn't be forever. The thought process here is tapping into experience that others have and to share that experience with us. In the end, to make us a more effective board and to create transparency. Folks talk about that a lot, and also just to give us a heads up on maybe where we're going off the rails, and maybe where we're right on. So I'd like to open that up for some discussion. Any thoughts on that?
Sure, I have some thoughts on that. First of all, I'll never turn down education. If you got somebody that wants to talk to me about how to do something better, I'm all in. My first concern, though, and it just has to do with the title and the way I have much more comfort with it when you're talking about what you're actually doing, because I feel like I've had it up to here with governance. I mean, we had a long lecture. Well, we don't know how many times we've been talking about governance. And what I thought is that our administration and our employees are all working on culture. And one of the ways we can lead as a board is to join that work. And so if we look at if we call it culture, if we look at our work, our board culture, our culture as a board, and how that affects the hospital, how the hospital's culture affects us, and that does lead into governance. It leads into how we interact with administration. It leads into how we interact with the public, and I think that's. I would be fine to do that if that's within the hospital budget and purview.
Sure.
I would be here with that.
Steve, any comments?
Yeah, I think it's a good idea. Very much so. I think the new members will be here for 4 more years. And we'll be around for a couple more years yet, and it'd be good to come to I really do think we're here for the same reason.
Oh, yeah.
I mean, I really do, and it just, we don't all have to agree all the time about everything.
We've proven that.
Yeah. Oh, it's just,
Well,
So
with
I'm-
5 individual people,
I mean,
we're not gonna agree on
if you're in
everything.
an athletic activity, you have a coach.
Mhm.
That's what we're talking about. Really, not somebody that has anything to say about any issue as much as how we're doing with the process.
Correct. And Mylan, to take off on what you were saying, I think it synchronizes with what administration and leadership is doing internally, working on better lines of communication, understanding one another, et cetera, et cetera. And that's where, I've had many mentors in my life, probably we all have. And to take advantage of that is a leading practice, and I think that's something we can do. Obviously, it doesn't have to be for a year or 2 years or anything like that, but we can.
We'll see
We can
how
fashion it. We can
easy
fashion
we
it.
do. And,
Yeah.
like a lot of things, sometimes you, like PT, you front load it and you have a number of visits and then you space them out as you get better. The question I have a little bit about this logistically is this something where we do this within the course of our meetings? A certain amount of time, 10, 15 minutes each time? Is it something we meet individually with our mentor? What's the logistics look like?
Yes and yes.
Okay.
So, the mentorship component would include observation during meetings. So, remotely, just watching the proceedings, seeing how things are flowing, et cetera, et cetera. And then meeting with board members for a short period of time, individually and meet as a group.
Can you folks sit closer to your mics for the deaf
Oh,
people?
sorry. Turn them on too.
Thank you. Even closer if you can. That's
Sure,
great.
sure. Sorry about that.
Thank you.
Yep.
Dr.
Okay.
Thank you.
So yes, it would be up to us as a board to shape how we would want this to work.
So this is an initial discussion, and then we can go forward from there.
We can, and I guess that's what we're looking for. Sam, do you have any comments?
Yeah, I definitely think I agree with the sentiment in general. And I really like, as Dr. Schmidt said, that it can dovetail very well and align very well with some of the cultural transformation work that we've already engaged consultants on and have a group who's working with us on. So I think bringing it in as part of that overall cultural transformation would be really helpful. As we continue to craft it, though, I think I definitely need to see specifics in front of me, either time commitment, what the objectives are of it, what we're hoping to come from it. And I do think we need to, the word governance being there and mentorship, as Mylan said, gives me a little pause, since the sheer just amount of it that we have gotten. And so I think that's why cultural transformation and making it a part of that might make more inroads, but I completely agree with the sentiment. And I have personal, what I would say, professional coaches. At work, I have different mentors as you're working on different committees and learning new things. And so I definitely agree with the sentiment, but yeah, I think seeing kind of what the plan would look like would help.
I agree with that, but I'd also like to know what it's gonna cost.
Absolutely, absolutely.
So is this something we leave with the chair then to begin to work out details, or how do we
If you
how
would
do we
like,
proceed?
we could, I could reach out to Matt Anderson. I mean, he's well respected.
And by all of us, I think.
Yeah.
Mhm.
And
So, yeah.
He understands the Minnesota.
And knows us
Yes.
personally.
Yes. I can reach out to Matt and get the details, and we can discuss that in the interim. Probably take it up at the next board meeting.
Sounds good. Agenda item.
Agenda item.
Do we have to email you that, or are you gonna write it down?
Please.
Really? Okay.
Well,
We like to document the world, right?
But you're taking the lead on.
I'll take the lead
Right,
on that.
okay.
Yes, I'll reach out to Matt and we'll get some information from him, cost, timing.
I think it'd be good for us to look, Patty, it's a great call, of like, all 5 of us bring a lot of experience to the table, and I think it might be good for us to figure out how to have discussions amongst the 5 of us, again, when it's not tied to these specific agenda items, so that we can have some of those things out. So maybe I would just encourage that each one of us, right, can come with ideas to the next meeting, which is, here's a structure that may work that the 5 of us, again, can do ourselves in an open meeting fashion to kick that off, because Patty, that's a great point. We want to be really aware of the costs, right, that might come with that.
Sure, we'll be mindful of all of it. Okay, let's move on to our next topic, establishing subcommittees. We have the first one where this has been a request in prior discussions to take a look at, does the hospital want to record and live stream meetings. And today we have WTIP here recording it, independent of the hospital. But the recommendation here is to have a subcommittee. Do we, as a hospital, want to take on that role? And there's quite a few logistical and regulatory things we have to consider if we were to do that. So I just wanted to open it up for discussion and see if we want to explore that further. And Sam, go right ahead.
Oh, I'm sorry, apologies.
No, go ahead.
Yeah, no, just again, having brought this up, I do think that it is a really important thing. Maybe not that we start with live streaming, but that we start by recording video and posting these to a publicly available channel. I hear the concerns around technology implementation, but also, respectfully, our school board has been doing this for years and they publish them. The City Council of Grand Marais has been doing this for years and publishes them to YouTube. The Cook County Commissioners has been doing this as well. So it's a pretty easy thing for us to talk to these other government institutions as well that fall under many of the same regulations. What are you following? How are you doing that to get kind of an easy an answer from them or a playbook to how to go about this? That's the governance piece of it, which should be considered. But also, we're in an open meeting, in a public meeting, and as you mentioned, anybody, right, can record either video or audio of this meeting. And so I don't know if it really does open us up to many legal risks beyond what we're already open to, because as you said, this can be recorded as far as either a technology plan and also a resource plan for how much energy this would take. So I think that would be helpful. And then I think, whether that's again coming from administration or coming from Mr. Feely, to your point, Patty, that makes a lot of sense to say, hey, what does this open us up to? Yes. Just because other institutions do it, how are they similar, how are they different, et cetera? I think that makes a lot of sense. I don't know if we need a subcommittee as much as we should have an agenda item next month. And Patty, those are great deliverables so that we can discuss it at that agenda, right? What's it going to take resource-wise and technology-wise, and from a legal perspective, can we do it, which will allow all of us to then answer
Legally,
we should
do we
do.
have to do it? That's the other thing. Legally, do we have to do it? Is it, in our best interest? All of those things need to be taken a look at.
I would ask, why the worry on the legally do we have to? And I don't want to take us back to conversations on trust and things, but you're leaning towards we should always not say or not show something. And that really makes me uncomfortable.
Well, I'm not saying we should or not show things. I go back to how things can be manipulated and how things can be misconstrued, edited, and you deal with technology all the time. I'm not so good with it. And I've got young kids, and there's things that I'm aware of, things that I'm nervous about, things I do and things I don't do. And I just want to know the ramifications. And I don't want to be, any of us to be set up to be abused in any kind of way, our images or what we say. And so I'm cautious. And that can be a good thing or a bad thing, it's just the way it is.
I appreciate your caution, and I think, I share it, but to me, having your have your own proof of purchase, if you will, really kind of helps so that if somebody is trying to manipulate something, you can say, no, this is the official document. We've handled it in this manner. We have this. We have safeguarded the security of these images and such. So, to me, it's additional protection.
Sure. I can see that. I mean, because there's the other side of it. Anybody can film anything and then it can go off and get, reconstructed by somebody with the help of AI and create stuff. There's all that. You can be paranoid about it, but just having our own document puts us in a position to at least fight back with, no, that's not what happened. That was all, doctored up.
Absolutely. No, well said.
So my recommendation is that we do establish a subcommittee to explore that, where we work with administration to get the numbers. What does this cost? Number two, what are the legal ramifications? Because there are many. There's many obligations. If we as an organization create this information. We are then responsible for it. So there's downstream impacts. And also, to Patty's point, the manipulation of the data, could be an issue. And we want to cover all those bases, and then we can come back to the board with a set of information, with the proper information. What's the cost? What are the legal issues? What are the compliance issues? And then we can make a decision whether we want to do this or not. So I would be happy to be on the subcommittee. Steve, Mylan.
I would recommend, if you're willing, Sam, because I think of all of us, you probably have the most current working knowledge of technology. And so I think you can run that would be helpful.
Since this is a, kind of to your point specifically, guiding around technology, is it more appropriate to make a technology committee that where we review and give recommendations as to, in this instance, technology and its use, both legal and cost and burden? I do.
Doesn't one have, doesn't another.
Well, I think what he's proposing is a little broader and maybe lasts a little longer.
Yeah. This is a short-term supplement. The work of the subcommittee's done, and it's done. We just end it.
So maybe we see how the subcommittee works, and then if that works particularly well,
We're really happy, then we can.
then we maybe
move on
want to
to-
do a.
This is a subcommittee of what, is my question.
Okay, the subcommittee thing, a committee, I guess, because we don't really have, it's not a subcommittee, it's a subcommittee of the
Subcommittee
whole.
of the board.
Whatever, yeah,
I mean,
okay.
it's
Subcommittee of the committee of the whole.
A
So,
work
yeah.
committee to look into the feasibility of doing
Can you
video
set a
recording,
goal of
publishing, or-
having it on the agenda for next month?
Yes.
Great.
It can be on the agenda for next month.
Excellent.
For review. So we'll work with Kimber and her team to get relevant information. We'll go from there. So, like vote, all in favor?
I don't think there was a motion. was there?
No, I'd still like a vote.
I'll make a motion that we
Go ahead.
develop a subcommittee to take a look at video recording and publishing of board meetings to consist of Randy
Great.
and Sam to work with administration, and they will come back to next month and give us a little report.
I will second.
All in favor?
Aye.
The second point is kind of consistent with what we've been talking about, mentorship, as far as a separate member code of conduct. And so recommendation, it again, is a best practice for boards. I think as adults, we all know how to behave, but this gives us the opportunity to put down in writing expectations, and also to memorialize, how should we conduct ourselves as board members, not only in the boardroom, but in the community at large, in our communications, et cetera.
I don't oppose that idea, but I think maybe the timing, I'm hearing a lot of committees and a lot of work that's going to be happening in a very short period of time. And I'm also cognizant of the fact that we're going to be talking with mentors about governance and culture, and maybe we want to wait until we have had a little bit of that education under our belt before we decide, before we start ruling. I'm concerned that if we start out by looking at rules that we're all going to follow, rather than how we're all going to play together, okay, that we're going to have, they're going to end up in an uncomfortable position. So let's just, if we could table that for now until we have an ability to at least try out some of this mentorship and see how that works. How's that sound?
I think that Board of Ethics, that can come out of the mentorship.
Yeah.
That'll be probably developed as we go along, and I think that's a part of the mentorship. Maybe it doesn't have to be separate. It'll grow from that.
I think it will too.
Oh, that's fair. That's very fair. wanted to bring this up as a,
Thank
as
you.
a topic. That's a good point, Miles. And I know, Patty, you brought this up last time. The next topic is rotation of board meeting locations. I know last year we met up at the Trail Center. We met at Portage and Lutzen. So I'd like, the opinion on that. Do we continue to do that this year?
We didn't give big numbers, but I'd like to because we're a vast county and not everybody can come in, to here, but they can, maybe if we go to their neighborhood or neck of the woods, they might be able to come. And it's just another opportunity for us to be available to the public, the people that support the hospital and that we do the work for. So I'd recommend that we try it again this year and see how it goes.
I think it's a great idea. I think after having done some of them last year, I would really like to see us say, what is a little bit different because we're in a different location? So if we are up the trail, I would like to hear from, whether it's a business owner or a citizen or a nonprofit group or the fire department, like, what are you dealing with up the trail here that we should know about? Same as up the Portage, same as the West End. I think that would be really helpful. So when we did this, we worked with, again, that district.
I'm supposed to be on silent.
So we worked with, again, that district to bring that in, because I think that's a great call, Patty. It's so important to have that. And then also that we really make sure folks know about it far in advance. I think right now, we notice about a week ahead of time. And so I think if we already know that we're going to be doing one in Lutzen, again, up the trail in Portage, it would just, the farther out we can notify people of that, the better of a chance I think we'll have of people getting it.
And I think if we can call, to your point, if we can key in some local resources to have a little presentation. I mean, we often have presentations, to the board, and it might be helpful to have somebody local, and that might be a draw to bring people in as well.
Or Jason's Bagels.
Yeah.
It's good bribery.
No, I think those are great ideas, Patty, I think.
That-
It's
You
good.
I
can develop
thought
a
it was-
schedule
it
and
was-
take a work with
The
management
numbers
here
that we
and develop
drew
a
last,
schedule and post it.
were a little disappointing, although I was one of them that didn't attend one of them.
Well, one thing could be, we don't have to do these at 9:30 a.m. So we certainly could do these at 4 p.m., say, when we do the remote ones, right? I understand it introduces, yes, other logistics and schedules to consider as well. But if our main goal, as you said, Steve, is participation of the citizenry in those local places, let's see what we can do to make sure they're aware of it and from a time perspective, it's available.
It could be that people are working for a living in the daytime, and it might be convenient.
To have it later, yeah.
It's possible.
Yes and no.
So we're going to go ahead and proceed with, that's my understanding.
Okay. Cool. So we'll work with administration to get the timing on that and the various.
Time and dates.
Yep. Okay. Now we're on to public comments, and we're allocating 10 minutes total, 3 minutes per speaker for anyone who wants to share their ideas or comments. Just to note that the board is here to listen. It's not a question and answer session, so anybody, if they want us to come up and sign in and have public comments at this time.
Where should I stand?
You can stand right there.
Okay.
Yep. You could introduce yourself to everybody.
Yeah, I'm June Tadikram, 332 South Shore Drive. And my only comment is that I would greatly encourage the board to record the meetings and to make them publicly available for people to watch after they've been recorded. That way, all of the stuff about people's work schedules and locations of the meeting would basically become moot. People could watch from wherever and whenever they want.
have
Could
to-
you introduce yourself?
My name is
please?
Kay Olson. I am a past board member, and I have been on the MHA trustee council for a number of years. I have a certified, advanced certification from the MHA. I have national rural certification, so I've got some background in what I'm talking about, but it's kind of fun to be on the other side over there and watch you guys doing this. But listening to some of your conversations, because I have been on the trustee council, I know that there is not a hospital in the state of Minnesota that records and puts the meetings out there. Not even in a hospital district, because someone specifically asked me, how about hospital districts, since they have to be public meetings? To not to my knowledge, unless it has just happened now at the beginning of this year, there's not one that does that. Some of the things that were brought up at our council meetings were the fact that if you decide that this is how you're going to do something, then if there's a glitch, if there's some kind of a problem, then it could be a problem as far as how you've had your meeting and how you dealt with things. There's two sides to everything. It doesn't mean that, maybe you can't work it out, but I just felt that as you're looking at your options, your committee, whoever you're doing that, you need to look at also what's happening in the state, not just here to see how things go for a hospital district. I think that you've had some really good conversations this morning. This has been very interesting. Hopefully you can continue to kind of delve into some of the problems and work your way through them. So thank you.
I'm Paul Terrell, member of the medical staff for going on 34 years. Two key points. The board has heard about the fiduciary responsibility to the board of the hospital. When I was looking at the minutes from Matt Anderson last week, or last month, I didn't see much about the responsibility to the constituents. And I think that needs to be emphasized as well. Transparency is really what this community is looking for. I would like to offer the example of North Pine Hospital District in Sandstone. Their meetings are held at 6:45 p.m., so working people have a chance to attend. They are on Zoom. If you go to their website, their passcode and meeting ID are there. You can also dial in by conference call and participate. And so I would hold that up as an example of a district that is much smaller geographically, but is doing much more to enhance transparency of their meetings. And I think we're at a stage in this community where if you do not proceed in this manner, the community is going to ask, what are they trying to hide? Thank you.
Okay. Anybody else? Any other comments from anybody else? Okay, we appreciate your time. Let's move on to the management report. Kimber, if there's anyone in particular that you would like to talk about, we have it in our board packet, but would you like
No,
to share
I
anything?
put the information in the board packet. If you have any questions, I would be happy.
Please ease the mic. If you could get closer to it or pull it through.
I have put the information in the board packet. If anybody has any questions, I would be happy to answer them.
I guess one thing in the management report specifically, call out the growing impact of Medicare Advantage in rural hospitals across America, and I read through the PDF. Thank you for sending it from the American Hospital Association. My question is, I guess, specific to those concerns that the white paper calls out from the AHA, what are the current things that we are doing and or tactics we're taking, strategies in order to counter some of the issues that arise from that? It's really helpful context there, and I'm wondering, when you bring up the negotiation with the insurers who provide Medicare Advantage plans, has Headwaters as an overall organization been able to make more way in their negotiations, or still yet to be seen?
Still yet to be seen, not yet. You gotta remember, they're one relatively new. as an organization. Two, they are working through those. Their predominant focus at this time is not Advantage plans. So they're looking at more of a high value option, and so doing some of the commercial pieces. And those that already have relationships with some of the other carriers, they're looking at Blue Cross, for example, and United, but it's not predominant Advantage programs that they're looking for at this time. But they're wanting to include that. So again, it's part of the value for us having that. And sometimes to our benefit, where we are located, one of the very few times our benefit is to our advantage, is the network adequacy is a big issue. And so there are times, it's why we've had the benefit with Blue Cross to say, you know, if you don't do something with us and we don't contract with you, then you don't have network adequacy. And I have used that, and I've used that for the last 12 years when we meet with carriers. And sometimes we're able, we have some better contracts than some of our other peers because of that.
Oh, thank you.
And we have to, and we're a little careful on how we talk about that, just because we can't collude either. We can't try to come together and negotiate with carriers and you know, I can't talk to Greg and say, well, what exactly are you doing so that I can make sure I can have the same thing. But we have some general ideas, and again, our distance and network adequacy is an important thing.
Oh, thank you.
I see, Nicole, you're still with us? I have one question on the management report. Could you give us just a quick update, your perspective on how the 2024 financial audit has been going?
Yeah, so far, so we just had our field work last week. The team was not on site with us, but they were working through all of the, you know, their normal requests. We were able to get everything returned to them last week. Typically what happens in the process is their team kind of pieces out different areas of the financial review. They work through it, then they have separate levels of review. So we're entering into this kind of second phase of the audit where their senior managers, their partners are getting their hands in and starting to review the files for more of that higher level consideration. So they'll be doing a little bit more testing around our higher risk areas, which are high risk for all organizations, including your receivables and revenue, some of those estimates with your third-party payers. So we haven't finalized anything with the audit yet. They've gotten everything that they've needed from a request standpoint, and now they're moving into the phase of their kind of general review. At this time, we've got our trial balance to a point in which we feel confident with, from the larger perspective, and we can start to get all of those cost report items out to their team as well. So they will start working on the cost report here very quickly, and that all of that will be finalized before the end of May.
Thank you.
Randy, I did looking at the community healthcare needs assessment follow-up, there's a line here that says a possible date for the presentation for the boards, and I think that's the clinic and the hospital board, is set for Tuesday, April 29th at noon, pending confirmation. Has that gone out?
I have gotten confirmation from two. I have not gotten anything back from you.
When did you request that?
I sent it in an email to all 5 of you last week.
Okay. So you're waiting from us, okay.
Yeah, and Dr. Schmidt
haven't
is not going
responded.
to be available, so he can't.
Well, unless you
Well-
can come up with
Yeah.
a Zoom option, which I would love, because I really
Yeah.
want to hear this.
I have to work with
And
them
you
on
said
that.
you had to work with them.
I have to work with them on that. So I've gotten information from 3 and I haven't from 2 of you.
Quick,
And then it's also Sachikamont Clinic confirming their board too. So
Yeah,
it's
completely
not just us.
I want to have a Zoom there for you. Let me say that first before I make this comment. I don't know how we can have a separate group having a conversation about recording or live streaming a meeting that is going to be an open meeting, and as long as there's 3 of us there, without also answering the questions we asked about before.
Which question?
If we said we need a subcommittee to look into the legality of recording a meeting. I'm saying this would be an open meeting if three of us
This
are
is
there.
correct.
Right? So I'm just saying that I think that we should, for both, personally, I would like to see them both recorded, obviously. But I think we just need to look at
They may
the
not-
same question.
Yeah, they may not be recorded. One, in the first place, I have to see if the 22nd works even with such a clinic. The other one is the RHI. They also have the ability to say whether or not they'll participate in it being with a Zoom option, participatory. And they might, and in that case, Dr. Schmidt could participate, he just would not be identified as an attendee, you know, and a participant.
I don't
just-
care. I
So,
got-
so it's that whole premise is that
Be
people
there.
can, you know, there is that piece of the
Incredible.
law that does allow for that remote participation from a board perspective, not from community members, so.
So this would be one in which case it would be live streamed but not
Well,
recorded.
not
which
live
would be
streamed,
important.
it would be Zoomed option, so participation in Zoom, it wouldn't be live streamed.
I'm using live stream because I don't want to use Zoom because it's specific technology. I'm trying to
Okay,
use
sorry.
the language that's that.
Yeah, whatever,
So-
if they use Teams or whichever one, it would be a meeting, it would be a virtual meeting option.
Okay, I just think it's, again, something that we should make sure we get clarity on. If we get
Yeah.
very specific clarity on the other one, I want
I
very
will,
specific clarity on this
yes.
one.
Well, and that's part of the, why we don't have an answer to you at this point yet.
Who's on
Okay, any other comments, any questions? Okay. Our next meeting will be a regular meeting on Thursday, April 17th, 2025, at 9:30 a.m. in this boardroom here at North Shore Health. And I'd like a motion to adjourn.
I'll move.
So moved.
Second. All in favor?
Aye.
Thank you, everybody, for your time, and appreciate the attendance, too.